who has a diagnosis of either a pineal tumor or a cyst. We're going to go over what the pineal region of the brain is and what the pineal gland is, what is a tumor or cyst, what the different types of tumors and cysts there are, why you might have gotten it, and then what some of the treatment options are. So first I want to define for you what a tumor is, because we use that word a lot, and for most people we equate a tumor with something that is growing or something that could be malignant. And the official medical definition of a tumor is really any mass or lump that is not part of our normal tissue. Once we think of a tumor, we think of it as benign or malignant, and we use a World Health Organization grading system that I'll talk about later. And all pineal cysts, if that's what you have, are benign lesions. What it does. So this is a cross-section of the brain, and this is a picture of going right in the middle of the brain between the two hemispheres. So if you look at this is the cerebral cortex. That's where we think and a lot of our business of the brain goes. A lot of those messages converge in what we call the brainstem, which is very important, and this becomes the spinal cord. So when we think to move, those messages go through the brainstem. When we feel something, they come up the brainstem. Deep in the center of our brain is a small gland. It's really right in the geographic center of our head. That's called a pineal gland. And a pineal neoplasm or a pineal cyst arise from that gland. Some of the other anatomy, this is the corpus callosum. That's the connection between the two halves of the brain. We're seeing that in cross-section. And back here is what's called the cerebellum, which in Latin means small brain. And that's a part of the brain that's very involved in motor coordination. So that's the pineal gland. What does it do? It's a small gland that secretes a hormone, and that hormone is melatonin. I think you've all heard of that because people are taking it as a drug when you're getting jet lag and so on, but it's involved in our circadian rhythms or our sleep-wake cycle. So that gland really exists just to produce melatonin. So what is a cyst, and how is it different from a neoplasm? Well, a cyst is a closed sac, and it has a distinct membrane, and it's separate from the surrounding normal tissue. And a cyst, by definition, is filled with fluid. It's not an infection. If it's filled with pus, that's an abscess. It's not a neoplasm because a cyst does not contain cells that are continually dividing and growing inappropriately. So I think you're all familiar with cysts somewhere. You can have a cyst in a sweat gland. Any kind of gland tends to produce cysts, just like the pineal. And if the fluid that comes out, if it gets clogged, it can form a cyst. There's other ways. These pineal cysts are benign, as I've already mentioned, and a lot of them are very small. In fact, when you get MRIs of the general population, most studies show that up to 1 or 4% of people, which means maybe 3 people out of 100 that you get an MRI scan, will have a pineal cyst. Larger cysts are more often symptomatic, but it doesn't always correlate with size. So I've seen patients with severe symptoms with very small cysts, and I've also seen patients with very large cysts who have no symptoms. But generally, the larger it gets, the more likely it is to cause symptoms. So what are the symptoms of a mass in this region? So the important question is then, if you have a diagnosis here, what do we do? So this is how I think about it, and I'll take you through the process. The first and most important thing is to decide, is this a neoplasm or a cyst? Because the treatment and thinking is very different. I'll show you MRIs from 2 of my patients. with no names, of course, showing you a neoplasm versus a cyst. So this is a cross-section, just like that brain picture I showed you before. So here you can see the nose and the mouth and the tongue of the patients and the head. Here's the cerebral cortex. Here's the cerebellum. Here's the brainstem. In the neoplasm, you can see all of this white tumor here is the neoplasm. It's lighting up with contrast. That's why it's so white. You can see it looks solid. It's got pretty irregular features. Over here on the right is a cyst. It's a different patient, very similar anatomy. And the cyst, I don't know if you can see it well on your computer screen, but it's right here. Okay, so when we see a neoplasm, and I'm going to talk mainly about adults again, how do we think through it? Well, a patient with a neoplasm needs surgery, generally. Not everybody's. There are some patients that we can make a diagnosis based on MRI and other things, but mostly we do, and because it's important to know exactly what type of tumor, or neoplasm, better word, it is. Let's say you're having symptoms, and then you have a small cyst. The big question for us is, are your symptoms arising from this cyst or not? Because we can remove the cyst entirely, and we can remove it safely, but it is a surgery. And so the question is, if we remove it, are you going to get better? And for that, the history becomes very, very important. My results have been very good, and we generally don't get serious complications, although there are always risks with surgery. So this is the same schematic you've seen before. The green arrow is going to point to the pineal gland, and there are two main pathways to get there. One is above a brain structure here called the cerebellum. So this is a natural membrane called the tentorium, and between the tentorium and the cerebellum is a natural space. So if you remove some bone here, you can access it on the top of the cerebellum and get all the way to this region. Getting that, but for the majority of the surgeries I do now, I do it in the prone position. Once we do the prone position, we remove a piece of bone like this. It's called a craniotomy. It gets replaced, so there is no skull defect at the end of the surgery. I'm able to split or gently retract a hemisphere of the brain, have a normal access pathway all the way down here to the tentorium, cut a piece of the tentorium, and then I'm looking directly at the pineal region and the cyst that's there. On top of the cyst are normal veins, important veins, that I end up dissecting the cyst from, and it's not stuck. On the side there are veins, and then once all the dissection's done, I just shave the cyst from the brainstem. I do not manipulate into the brainstem at all because of its important structures, and it's a very effective surgery. I'm currently performing probably 50 or more of these surgeries a year, and the results are quite good. The majority of my patients spend one night in the ICU. You should wake up right after surgery. You should be able to talk and move everything. And after a night in the ICU, the next morning, I want my patients up and walking around. We go to a regular room, and usually 2 days after surgery, you'll be released to go home or to a hotel if you're from out of town. So what are the risks? Well, first of all, knock on wood, I've never had anybody die from this surgery. Anytime you have a general anesthetic, we're concerned about a heart attack or an anesthetic reaction, so we're very careful with that. But with modern anesthesia, the chance of that is very low. Most of my patients wake up in the same condition they went in neurologically, because they may have some symptoms with vision and so on. And certainly after surgery, they have no cognitive deficits or paralysis, anything like that. I've never had that happen. Most patients with visual disturbances get better. If there is a problem, it tends to be that temporarily the visual problems can worsen. Or if you did not have visual problems, sometimes that can happen. But those are temporary. And then there are other complications we worry about, like wound infection and a urinary tract infection and so on. And, those are real risks, but again, it's generally safe. And so while we do not want to put a patient through this who's not suffering, if you're having significant symptoms and it's been going on for a while, it can really be life-changing. So it's very gratifying for me when a patient who's had headaches for several years, and often my patients end up dropping out of school or they can't go to work, and they end up resuming a normal life. So it's about 2 days in the hospital. I usually see the patient 2 weeks after surgery to remove the stitches. And for patients that are doing well, our next visit is often a year later to get a follow-up MRI scan.